an educator and a graduate, of course, of McGill University. She specialized in the field of orthopedics to receive her FCAMPT qualifications in '91, and she's certified in intramuscular stimulation. Her career path led her to becoming an instructor, examiner, and ultimately a chief examiner for the orthopedic division of the CPA fellowship examinations. As I mentioned, we had the pleasure of receiving her at the JRH earlier this year for her course in mobilization of the myofascial system, assessment and treatment. And today we're glad to welcome her back for a case study. So thank you again, Doreen. And
all right. So this is my first time giving a Zoom lecture online, and let's cross our fingers and hope everything works out. If not, Loredana has my phone number, so we'll try that out. I'm very happy to join you all today and to talk about my favorite topic, actually. So I'm gonna jump right into that share screen and keep my fingers crossed here. And you guys let me know if you can see. All right, how's that? Loredana?
Very good. Yes, good? I see it.
Terrific. All right, so I changed the title a little bit. It's Assessment and Treatment in Relation to Knee Dysfunction. And I'm actually gonna have 3 small little cases, okay, to illustrate how the fascia approach can be used with that. Okay, so basically, for those who don't know me, for those who have taken the course with me, I'm glad to see you back. And some of the stuff that you hear today, you might have heard already within either the theory course or the fascia course. But for those who don't know me, I think Loredana kind of did the introduction quite nicely. So despite all of the training I had in manual therapy, I had a fair amount of clinical frustrations with certain cases that were doing well in treatment, but they had difficulty maintaining between treatments, even though the patients were really doing the exercises, whether the exercise was a mobility exercise or whether it was a stability exercise. And so that's what got me studying, the whole other aspect of fascia that we hadn't heard very much of certainly in the field of physiotherapy. So that's my career trajectory. I also have done a whole number of courses throughout the years. I've lost count how many now because Elaine and I, my business partner, had a company that organized courses for physios in Quebec. And so I got a chance to study with, Gwen Gell, David Butler, Shirley Sarman, the whole gang of people, and wonderful courses. And also, so despite all that, I still have my frustrations. So this system of what I call MMS, which is Mobilization of the Myofascial System, was redeveloped as a result of my clinical frustrations. And so basically, I used Tom Meyer's book, I will talk about him in a moment, called Anatomy Trains. That was my guideline for treating the fascia from a physiotherapy point of view, because there are other professions that are looking into the fascia, in particular structural integrators that come off of the training by Ida Rolf. And that's more in the massage therapy world. But from a physiotherapy point of view, back at the time in the early 2000s when I started to look into this, there wasn't very much in the physiotherapy field aside from the myofascial release of the John Barnes thing, which is something different, but not quite what I do. And so basically I seek out treat lines of fascial tension that can maintain a dysfunction, whether that dysfunction is articular or muscular. So it brings about the concept of victim versus criminal. And so for an example, if you have a recurrent problems in the anterior aspect of the neck, and you've been using your mobilizations, your AP, your cervicals, and as I said, you get good results with treatment, but it tends to come back all the time. That's when I started to understand that the tension in the front of the neck could be due to something in the front line of fascia, whether it was superficial or deep. And so in some examples, for an example of if a woman has had a C-section, the cesarean section scar can actually have good mobility, but in relation to the anterior aspect of the neck, it's almost like there's a short cord between them, and there's some tension there that can be a factor that maintains the pull of the C-spine forwards. And so in this case, the victim would be the neck, and the criminal would be the C-section scar, okay? All right, so this led to the development of the system, and finally this book that was in the back of my head for the longest time saying, write me, got written in 2017. And so basically this approach is based on manual therapy for the articular, muscular, and neural systems, as opposed to structural myofascial therapy, which is really much more around the muscular systems. So I'm going to be demonstrating a couple of techniques of the structural myofascial therapy because it is a useful thing, and so I integrate a lot of that with what I do. So, clarify, I'm not a fascia therapist. I don't do just that. I'm a physiotherapist with lots of tools in my toolbox, one of which is mobilization of the myofascial system. So they're present throughout the body. Historically, they've been ignored. We see the things as being compartmentalized, but basically in reality, everything's connected. And it's not just the muscular or musculoskeletal system that's connected, it's really the fascia around muscles, joints, yes, but nerves, organs, vascular system. So it becomes a body-wide communication system between the various systems of the body. And they are innervated, so they can be contribute to painful syndromes. They also have a strong mechanical component that can limit mobility. So keep that in mind. So that's about as much theory as I'm going to give you today. Just a quick definition, which has been brought about in 2015. There was a task force that got together to discuss what the definition is. It's kind of a dry definition as far as I'm concerned. A sheath, a sheet, or any number of dissectable aggregation of connective tissue that forms beneath the skin to attach, enclose, and separate muscles and other internal organs. So that's the definition, okay? So the questions I often have been asked is like, okay, so if fascia is around the muscle, how can you differentiate muscle from fascia? Well, in one word, you can't. There's muscle tissue. So what you see here is, in the picture on the left, is fibers of muscle, and that web-like stuff in between is the fascia, okay? And so the fascia accompanies the muscle tissue. They are integrated synergistic units. So one way to differentiate is, whoops. Is it possible to take off, mute
the microphone, correct.
Microphones?
We should all be muting the microphone, yes.
Yeah, until the question period, because I'm hearing some stuff. Okay, so fascia is the form, but muscle is the mover.
It's in the top right-hand corner of your screen box. And you just press mute.
Okay, thank you. All right, now I did put this up here because I thought it was kind of interesting to differentiate pain coming from muscle versus pain coming from fascia, okay? So muscle pain, dull, beating, throbbing. Fascia pain is kind of interesting. Throbbing, scalding, stinging, hot. Unusual. It suggests innervation by both A and C fiber nociceptors, but when you look at that, you tend to maybe misinterpret it, fascia pain, as coming from neuropathic pain. So it sounds like a nerve pain, but fascia can present that way. So keep this in mind. All right, so again, just to give you an idea of the different layers, underneath the skin, you have the adipose tissue, and you have that first layer of superficial fascia, which is like directly underneath the skin, not very deep at all. You go a little bit lower, you get a deeper fascia, and then you hit the epimysium, which is the covering of the muscle. And so when we use the techniques, in particular the structural myofascial therapy, gets into that deep fascial layer. So these are the typical pictures of what we're used to. What I tend to show to people about fascia is more the picture on the right side, whereas, and I link it to the covering of the muscular system, let's say. It's almost like a roast of beef, that white tissue that's around it. Sometimes it's thin, sometimes it's thick. It's the covering of it. And so people can grasp what fascia is when they look at that picture. Keep in mind that fascia also surrounds the vascular system in blue and the nerves. So you can get interface problems with mobility of the nerves and the vascular system because of tight fascia. So again, this is a typical thing of what we see when fascia is discussed. A pull on one corner of the connective tissue framework exerts a pull throughout the whole structure, almost like you're pulling on one end of a sweater, which distorts the whole thing. So it affects muscles, bone, nerve, blood vessels, glands, and organs. So in this particular case, if the pull is coming from below the sweater on the right, that might not be where the patient complains of pain. It could be complaining of pain in the right shoulder, for an example. So let's talk about case one, myofascial dysfunction in a post-op knee. Okay, so let's say the patient is missing the last few degrees of knee flexion and or extension. They've hit a plateau with moves to the knee and exercises. Their quads are inhibited despite exercise, despite muscle stim, despite everything. Okay, so this is the book I was telling you about, Tom Meyer's Anatomy Trains, that describes the linkages of fascia and muscle that wind through the body. I'm not going to describe all the lines of fascia. I will describe those that are particular to this particular case history, okay? So superficial front line starts from sternocleidomastoid, goes anteriorly, very superficial to the sternum, ends at the symphysis pubis, restarts at the origin of the rectus femoris, all the way down the quads and into the toe extensors, okay? So we'll keep that in mind when we do certain quads techniques. You'll understand why, in this case, if we're looking to evaluate the superficial front line of fascia, we're going to use plantar flexion of the foot to see if there's tightness in this line when we're anchoring the quads, okay? So it involves all of these structures, including rectus abdominis, patellar tendon, tibialis anterior, etc., etc. Okay, this is some ways to stretch it out, and certainly not the only ways. So I love yoga. I think it's a great way to move in chains, as long as you do it without losing your form and you're able to stabilize and not just sink into things. Now, this is the deep front line. So what you see here is in the dotted line is that superficial front line that I just described to you, going to the symphysis pubis. So that superficial one is anterior to the sternum, okay? Now, if you go behind the sternum, and what's behind there? Pericardium, diaphragm, anterior longitudinal ligament, anterior sacral fascia. Guess what? Pelvic floor is all included in here. Adductors all the way down to the feet and ends at tib posterior and some of the toe flexors as well. So what is tib posterior? How do we put it on stretch? We put it on stretch with a combination of dorsiflexion, eversion. So keep that in mind when we're trying to look at tension in this deep front line, okay? So these are all the structures that are involved that I've just described, including psoas, iliacus, diaphragm, as I said, posterior and anterior, pericardium, all. And what's not in that picture is everything related to TMJ, infra and suprahyoid muscles, the cranium, the facial bones. So it is often a problematic line, especially with the sitting disease that we all have, that we spend way too much time flexed, and we don't generally tend to do anything to stretch in the other direction unless our sports or activities bring us there. Okay, so quadriceps technique, MMS, indications. It should be taken into account in the case of non-articular restrictions of the knee, especially flexion, but also could be extension. Recurrent problems with the pes anserinus area, patellofemoral joint, popliteus, and tibial tuberosity. So it's not just the knee joint, but all the soft tissue structures in and around that area. So recurrent pes anserinus pain, patellofemoral, where we've mobilized locally, and we've looked at the IT band as best as we can, and we're still having problems with symptoms coming from there. So these will be examples of what you can go and explore. So the first one here is professionally called wiggle woggle, and I didn't coin that name, another therapist that I work with did. And it basically what you do is you almost pick up the quads tissue either proximally or distally towards the knee, and you pick it up in an almost an anterior direction, so a PA, almost like a suction type thing. And then you start moving the tissues medially laterally and see if there's any restriction. So it's not stabilizing one hand and moving the other. Both hands are moving equally this way. And oftentimes what you feel if there's going to be problems there is tension, usually on the lateral aspect of the vastus lateralis. It's a really kind of nice way to get to vastus intermedius, which is quite deep often. You almost feel like something is tight within the vastus medialis and its connection to the femur. So you can work locally like that, as I said, center, medial, lateral aspect of quads, closer to the knee, away from the knee. And you can also move the tissues in a clockwise, counterclockwise direction and see if there's any restriction under your hand. Now, the next few techniques will be using this particular concept, which is that we choose a recurrent articular dysfunction or a trigger point that is recurrent or tension that keeps recurring in a muscle. You anchor yourself there. And then you seek out and release fascial lines of tension, looking for the early tension between the two hands. And so once you have that, you can either work with oscillations, and that's grade 3 minus, 3 plus as a progression, or you can work with a sustained pressure. And it's the most common approach with MMS. Okay, so here's an example. So you have tension that recurs in the quads, or you're missing either the last degrees of flexion or extension, because this restriction can apply to both. Okay, so oftentimes people that have had surgery in the knees, their soft tissues have been abnormal for the longest time. They have the surgery, the knee joint is better, but the soft tissues remain problematic. And oftentimes fascia is part of that. So here I am anchoring the quads distally. So I'm anchoring it in an anterior and cranial direction because I want to explore the foot below. So what I do then with the right hand is do a combined motion of dorsiflexion eversion. If there is no tension in this line, I will feel absolutely nothing in my left hand that is the anchor hand. If there is tension in this line, what I will feel is my anchoring hand will want to move posteriorly and caudally almost as soon as I start moving the foot. And it happens fairly quickly. So it's like almost a short cord between the two hands. And so if you feel that in that with that motion, then you just work by stabilizing with the left hand, oscillating with the right hand until you feel a release between the two hands. You can also explore that superficial front line by adding plantar flexion and C. So it's the same anchor, but you see by plantar flexing if there's an increase in tension in your anchor hand. And the anchor, of course, can change position. You can go a little bit more proximally, a little bit more medially, a little bit more laterally. Don't be afraid to kind of think about the vastus intermedius in this particular case. Now, the technique is done here with the knee in neutral, but it can certainly be done with a little bit more flexion and by support of the therapist's knee with your own knee or with pillows or whatever. And it's something that is you can keep in mind when you're actually working restrictions. Now, same concept, if we look at that deep front line, same concept with pes anserinus. So, you know, it's not always about the pes anserinus bursitis. Sometimes, yes, there may have been a bursitis, but oftentimes the fascial tissues in and around that area are tight in relation to this line. So you hook onto various aspects of the pes anserinus, hook in a cranial direction and add dorsiflexion eversion. Once again, there should not be any tug or pull on your anchor hand until the very end of the dorsiflexion eversion. If there is, you work it this way. Same thing with popliteus, which is kind of underneath the knee. And we tend to think, oh, you know, it's Baker's cyst, and not necessarily. It could be popliteus, which is part of your deep front line. So people that have restrictions or pain in the posterior region of the knee, go explore this particular line of fascia. Patellofemoral joint, also really interesting. So here I'm doing a traction of the patella in relation to the femur and adding dorsiflexion eversion. When this line is tight, what you feel is that the anchor wants to pull down into posteriorly towards the femur. So that's not an ideal condition when somebody's walking to have increased patellofemoral compression that way. So you can keep the anchor with the traction and add oscillations with the dorsiflexion eversion. You can also explore the various glides of the patellofemoral joint and repeat as well, and make sure that there's nothing connecting too tight in between the two hands. Same thing with tibial tuberosity. So the Osgood-Schlatters people, that would be more in the young folk, but oftentimes if you do like a lateral to medial pressure and you add the dorsiflexion eversion with this, you'll find that it increases the tension on the thumb there. And it feels like a good pain when it's being worked, when it's appropriate. So we talked about the front line, but there's also a lateral line that can affect the knee. Okay, so the lateral line, as you see, is yes, ITB peronei, but also intercostals, okay, all the way up to sternocleidomastoid, levator scap. So all of these structures, oftentimes people will complain of pain around the ASIS, PSIS, and we say, well, there's no joints there. No, but there's lots of fascia, okay? So keep this in mind for the next few techniques. The IT band is notoriously difficult to work, and I find that these techniques, which is the structural myofascial therapy, so this is not MSM, this is structural myofascial therapy taught by Betsy-Ann Barron, who's the one who teaches with me. And so here she's demonstrating myofascial release starting at the lateral aspect of the iliac crest, continuing towards and around the greater trochanter. And so she does what we call like a little Y motion to open up the fascia. And she does that with and without movement. And the movement is a small posterior pelvic tilt and release. So she starts off in the area of the glutes and also can stand behind the person, this time using soft fists, can repeat with the elbows to sink into the posterior tissue of the greater trochanter. There's very little sliding motion, so basically stretching the gluteal tissue away from the greater trochanter, again, with and without motion of the pelvic tilt. And then you can go into the same Y-type motions along the iliotibial band. Now here she's going from proximal to distal. You can also do these same maneuvers from distal to proximal because the band needs to move equally well in both directions. And you can also do it in the center of the band, the anterior aspect of the band, posterior aspect of the band. As we go from the heel of the hand towards soft fist, towards tip of fingers, as you see there, it gets progressively deeper. And you get, again, you can do this with small pelvic tilts. And then this one feels lovely, using the forearm. So basically a one slide down from the greater trochanter all the way towards the knee, with and without pelvic movements, and also with and without small knee flexion extension. Okay, and again, you can angle the angle of the forearm being center, IT band, front of it, back of it, but it's a nice way to kind of release that whole area. And finally, you can continue on with the rest of that lateral leg by continuing along the lateral aspect of the knee. Little Ys again. This time you can play with plantarflexion, dorsiflexion, ankle inversion, eversion, and then finish up at and around the heel. So this is like almost a little recipe that's looking at that whole lateral line that can affect the knee. So keep this in mind when you hit a plateau with your post-op people. Okay, case 2 is a hip-driven knee pain. Okay, so not all knee pain comes from the knee. So this is an example of where you can use the concepts of the fascia in regards to the hip that might be influencing the knee. Okay, so here's an example. Subjective, vague medial knee pain with walking and sitting. No history of trauma. So you're not looking at any ACL or MCL type of problems here. Objective test, the femur is in slight internal rotation relative to the tibia. Okay. The knee exam is essentially clear. Full range of motion, ligament stress tests are negative, patellofemoral tests are negative, Ober test is negative. Okay, so what's causing this knee pain? Okay. So if we look back here, what is the functional complaint? Walking and sitting. So what functional tests can we use? The sitting, we can use the functional tests of a quarter or a half squat. And for walking, a one-leg stand test. So we're wanting to look, is there a change in position or movement of the knee and or hip when we do these tests, okay? So here is an example of looking at the alignment of the tibia in relation to the femur with a small squat. Now, normally the tibia starts off in slight external rotation in full extension relative to the femur. And so at the beginning of this flexion maneuver for the squat, the tibia will derotate to neutral, and then it should pretty much stay in line with no other twist. So let's see what you're going to see here is a normal test. So there we go. So it stays pretty much in line. So there's no twist of my distal hand with the squat, okay? All right, so now let's take a look at what's happening on the other side and take a look at, as she's going through a squat, what happens with my right hand, okay? So here we go. All right, do you see that external rotation of the tibia? That's exaggerated with the squat there. So external rotation of the tibia and or internal rotation of the femur, right? We're in close packed position. So that is non-optimal biomechanics for the knee. But does that mean the problem is coming from the knee? Not necessarily. Let's see what's driving this. So let's say you've done your knee exam and you're wanting to see, okay, maybe this is coming from the hip. So you take a look at the hip in relation to the pelvis. Is it sitting in neutral, or commonly what we see is that it's sitting anteriorly? So in this particular picture, if you get in the middle of the crests and the posterior and anterior aspects of the hip joint, the hip joint is pretty centered in relation to the hip. Now, what happens with this, with motion though, okay? So with motion, when you go into a squat position, the hip should stay centered in relation to the ilium. So we should see or feel no anterior slide, no internal rotation, okay? That's a normal test. This is what the optimal biomechanics for the hip in squat. So here is, in terms of a more dynamic thing, the good hip stability with the squat that you see. There we go, stays nice and centered, beautiful, okay. Great, and now compare this. Now what you see on the right, I couldn't find the video that I had with the squats, so I used the one leg stand instead with this test, but watch what happens with the right hand. Okay, the right hand will glide anteriorly with the one leg stand. Boom. Anteriorly and with medial rotation. One more time. There we go. That's non-optimal mechanics. So normally with someone with this test being positive, what you will see in terms of the positioning is that the hip sits anteriorly. So does that necessarily mean that the problem is coming from the hip, that it is a hip capsule problem? Not necessarily, okay? So if you're looking at some research here, Powers and company in 2009, they noticed that an increase in hip internal rotation with various functional activities like drop, jump, running, step down in patellofemoral pains compared to controls. And so there is a problem with an increase in hip internal rotation in relation to the patellofemoral pain in particular. So the abnormal hip femur kinematics can be caused by diminished hip strength. Yep, that could certainly be a weak glute med, but it could be a neuromuscular control problem or abnormal muscle recruitment patterns. But I would add in this case that it can also be, these muscles can often be inhibited because of a tight fascia. Okay, so that's, obviously they weren't talking about it back then with Powers. So in a hip-driven knee problem, when you correct the hip, it makes the knee better with the squat test. So what is the problem with the hip? Is it necessarily a capsular restriction? And I would say no, okay? So we use a load and listen test for this. It's an important tool in MMS. It helps to assess the myofascial vectors that can influence the joint and is a guide to treatment. So I'm going to demonstrate what I mean by this. So in this case, with the hip sitting anteriorly, what we're going to want to do is do an antero-posterior glide of the hip in relation to the femur. So we could say, yes, we are assessing the hip joint. However, with this test, we're not so much interested in the resistance that we feel when we do the glide, but more importantly, when we let go of the glide, where does that resistance take us? Okay, so in this particular test, the patient's supine, hip in neutral, you palpate the ilium with one hand, the other hand performs an AP glide of the hip joint, you note the resistance to the glide. And on release, that's why I've got it in yellow, you feel the first vector that pulls on the femoral head. So if the restriction is articular, the end feel of that glide will be hard and fibrous. But more often than not, it is not that is causing the restriction. If there is a myofascial restriction, the therapist will feel a certain resistance to the accessory movement, yes, but with a softer end feel. And then most of the information is gleaned if your therapist pays attention to the release part of the test, listening for vectors that can pull on the hip joint. So these vectors might be long, short, pull in a cranial, caudal, medial direction, can be superficial, deep. We actually go into this test a fair amount in the advanced myofascial course. There may be a combination of neuromuscular vectors, so an increase in muscle tone. There could be visceral vectors, could be muscle fascial vectors. So there's more to it than you think. So for this load and listen test for the hip that's sitting anteriorly, the possible vectors, there are a whole slew of them, but what we'll focus on today is on release, the first vector is that it pulls medially towards the pelvic floor and into external rotation. So that would signal to me, okay, I've got to go evaluate pelvic floor. Now, I'm not a pelvic floor therapist, but I can access the obturator internus muscle externally. And that is often a source that is rich in tension, okay? Keep note that, you know, with other possibilities, you know, if it stops at the symphysis pubis, there's no rotation component. It could be the adductors or pectineus that's pulling on the head. If it seems to be a longer vector above the inguinal ligament, it could be iliacus, psoas, or even more of a visceral vector. So there are other possibilities, but let's keep in mind the obturator muscle. So just a quick little reminder of where this sits. So basically it forms on the inside aspect of the greater, my goodness, the ischial tuberosity. Okay, so the fossa, and then it comes over to attach to the greater trochanter. And what you don't see here is that alongside from one end of the greater trochanter to the other greater trochanter, there is fascia inside the pelvic floor that connects all of this. So basically, it doesn't, act alone. So the obturator internus can be accessed. It's part of the pelvic floor group of muscles. So tension in this group, people that tend to butt grit, can push the head of the femur anteriorly and cause non-optimal biomechanics at the joint. So with the squat test, the femur is seen to further increase its anterior glide and or internally rotate the femur. This might have an impact on the knee, okay? So this is how your anchor is on the medial aspect of the ischial tuberosity. You slide up as far up as you can, and then you anchor in a medial to lateral direction. There you go. And then, so that you can feel some local hypertonicity in the anchoring hand, but then you want to see what happens when you go explore the sacrum, for an example. So the muscle doesn't go all the way up to the sacrum, no, but its fascia does, because this muscle is part of the deep front line of fascia. And if you remember well, the anterior sacral fascia is part of this line. So you can, as soon as you do a PA on the base of the sacrum on the right side, or it could be central on the base of the sacrum, or even the opposite side. Again, when there's tension in this line, you feel an immediate increase in tension in your anchor hand, okay? So if I'm working in this area, I tend not to oscillate very much because it is a sensitive area. So I tend to just get into the first resistances of the tension between the two hands, and I just hang out there and wait and see what the body wants to do with this. And ultimately, within 10, perhaps maybe 20 seconds, you feel kind of a release or a sigh in the system, and things let go, okay? So you can explore it in relation to the sacrum. You can explore it in terms of the ipsilateral or the contralateral diaphragm. Again, looking for that immediate tension between the two hands. You can look at the central diaphragm as well. And you can also go explore it in relation to the greater trochanter, either the same side, and I would even add opposite greater trochanter, if you remember that whole sling that I was explaining to you. And that's how you work it. Now, all of these techniques are done with the lumbar spine in neutral initially, but they're progressed with the lumbar spine in extension, which further increases tension on the deep front line. So after you release this fascial line, what are we going to do? We're going to recheck the position of the hip in relation to the pelvis, see if it's changed. Reassess what happens to that squat and see if the hip now stays centered, and assess its effect on the knee with the squat test. And so in this particular case, and this is a pattern I see often, release of the obturator internus and its deep front line of fascia will help the knee in the sense that you don't have this internal rotation component of the femur that's tugging on the knee all the time. So that's how we use the MMS for the knee, but by working the pelvic floor. So third case, foot-driven knee pain. And same subjective exam that we saw before. So knee exam is negative, and we repeat that squat test and we find the same things that I showed you before, okay? However, this time we noticed, there's a little something going on in the feet. So what's going on in the feet here? If you look at this picture, the left talus, can you see that it sits a little bit adducted in relation to the tibia? And that the left forefoot kind of sits into eversion. And so this person was asked to stand with their feet parallel, and that's about as comfortable as they can get. The first ray, so that the first ray being navicular, first cuneiform, and first metatarsal, basically sits into external rotation, so lacking internal rotation, which is what we need for push-off, for supination. And the femur, you don't see it here, but the femur is also in relative internal rotation. So, okay, how much of this foot position is restriction in articular versus myofascial? So let's take a look. So this is showing you, you can also eyeball it, but you can also feel both sides of the talus in relation to the tibia. And so what I notice here is my index finger is definitely sitting more medially if I compare it to the other side. So this is normal and abnormal foot mechanics with a squat. So what you'll see here on the left-hand side is that the talus stays centered in relation to the tibia throughout the whole squat test. Yay, that's what we want. And now if you notice on the other side what happens here, do you notice that the talus on that side increases its adduction, which then tends to have effects on the biomechanics of the tibia and femur, okay? This is non-optimal talus. So correction with a foot-driven knee problem, correction of the foot makes the knee better with the squat test. So what's the problem with the foot? Is it necessarily a capsular restriction? If it is it the hind foot, the forefoot, or both, okay? And so in order to dorsiflex completely at the talocrural joint, we need to assess the mobility of the talus and also the mobility of the forefoot. The forefoot needs to be able to do some internal rotation. So we shall go through a little bit of this. So in terms of the talus dysfunction, could the adduction of the talus be due to the ability of the talus to rock back, the inability of the talus to rock back dorsiflexion? Is this dysfunction necessarily a joint, or could it be a myofascial component to this dysfunction? So we know from typical manual therapy that we tend to do two things at the talocrural joint. One is a posterior glide. And then the second thing that we assess and treat is this talar rock, okay? So here we're comparing a talar rock on the left side, which is good. It's got nice mobility. That talus is able to rock posteriorly. Compared to the other side, that's it. That's the restriction. Now, again, that could be an articular restriction, but it could also be a myofascial one. And so you saw that what I'm trying to do here is going to explore the medial aspect of the gastroc soleus to see if there's a connection between the tissues there and my thumb that's on the talus. There we go. So looking for the myofascial vector. So my right hand stays there and my left hand pulls up on the fascial tissues of the gastroc soleus, and I'm looking for the area or areas that have an immediate impact on the talar rock. So you notice when I'm in that particular place, I have zero talar rock. And so this is where I'm going to be starting using a technique called release with awareness, which was developed by Diane and L.J. Lee. And in the so I'm not going to explain to you the whole concept because that would take too much time, but I just wanted to show you that this was done on the left foot before, and one treatment of release with awareness on the left foot. This is the position after.
Excuse me, Doreen?
Yep.
I didn't want to interrupt, but excuse me for interrupting. I just wanted to mention that it's almost 1 o'clock, but I didn't want to rush you. We've added, Byra went ahead and added 15 minutes to the presentation.
Okay.
So
I'm just about done, actually.
Perfect.
Yeah,
I didn't mean to rush you, and in case there are any questions.
No, great. Yeah.
Perfect. Thank you.
So the release with awareness involves the talus, but also working the forefoot, that first ray in relation to tib anterior is what you often see as problematic. And then finally, so the tib anterior, that can be a myofascial problem that's pulling up on that first ray. And finally, ending with the intermetatarsal fascia with an AP of the talus. So when you do this technique, you have to do the whole hind foot and the forefoot and underneath the foot all at once. You can't just treat the talus, for an example. So once you do that release with awareness, again, any change in the one-leg stand or squat tests, what's the effect of the treatment of the foot on these functional tests at the knee? But keep in mind that the treatment of the foot can also have an impact on the hip and the SI joint as well. So in terms of research, it's really exploding. There wasn't much, certainly at the very beginning, and there's more and more research being done. I could have a whole other hour just on the research in relation to the fascia. There have been a number of international conferences on fascia research. The first one is at Harvard in 2007. And the next one is supposed to be in Montreal, if all goes well, in September 2021. So the first conference, there was hardly any physios. It was mostly, you know, structural, myofascial therapists, chiropractors, osteopaths, some plastic surgeons. But now the physio world is kind of waking up to this. So it's nice to see. I just kind of put in a few studies in relation to the knee that you might want to look up. And basically, you know, welcome to the world of fascia. And if you have any questions, my email, this is my personal email address, and my website is as follows. So there we go. I shall end the show and be available for questions.
Does anyone have questions for Doreen in case you don't have the microphone available on your computers? If that's the case, you can type it on the chat and I'd be happy to relay the question to Doreen.
Hold on. I'm not seeing you anymore. Okay. Can I do stop share? Yes. There we go. Okay. I'm trying to read the questions in the chat. Okay. It's mostly technical things.
Okay. They must have texted you individually on the chat because there is that option instead of posting to all.
Yeah, but I don't see any questions on the chat per se.
No, that's it. Neither do I.
No. So, you know, I'm hoping that this kind of, you know, opens the doors that treating knee problems, we need to look sometimes, you know, oftentimes up and below and sometimes even higher up than the hip. So it's not always at the knee, and in the knee, just think about the fascia.
Mm-hmm. Doreen, I see a question that was directed to me for you, asking if the presentation will be available. And I know that you had given us your consent to record the presentation, so that in the coming couple of weeks, hopefully should be posted up on the career website. And we really thank you for giving your consent, because it really helps us a lot with the clinical assessment and treatment of patients. So
I just want to share. I'm, you know, just like, this is like amazing stuff, and I love to go to work to go play. Honestly, it allows me to be creative, but at the same time, you know, retest, so that we're sticking to a little bit of analytical way of looking at things.
Very good. A big thank you again to you, Doreen, and to everyone who's in attendance. And I just ask, for those of you who didn't mention your name and your discipline, kindly email me. I had put a note in the chat, and you could just let me know, just for attendance sake. So thank you very much.
Thank you very much, Loredana.
Okay, take care.
Okay,
bye everyone.